Good evening, everybody. Welcome to this webinar entitled Meet the Expert, Real-World Data in VTE, the RIETE Registry. My name is David Jiménez. I'm a respiratory physician at Ramon y Cajal Hospital, and I'm more than pleased to introduce my very good friend and colleague, Professor Manuel Monreal. He's an internist from Germans Trias y Pujol Hospital and the father of the RIETE Registry. Welcome, Manuel.
Thank you, David.
Well, we have a busy agenda today. During the first 20 minutes, we will be discussing different issues around the RIETE Registry, and we will dedicate the last 10 minutes to answer your questions, and you can submit your questions anytime through the website. So, Manuel, my first question is, why did you decide to create the RIETE Registry?
Well, I still remember the day when everything started. I was in the hospital. I was on duty. It was a Sunday afternoon, and I was urgently called to the neurology service. There was a lady there that has been admitted 1 week before because of spontaneous bleeding in the brain. And I was called because she suddenly developed chest pain, respiratory insufficiency, and so on, and she was diagnosed with an acute pulmonary embolism. And my problem was how to manage, how to prescribe anticoagulants to a patient that has a severe bleeding in the brain just 7 days before.
Because, Manuel, these cases are not so infrequent in clinical practice.
They are not that infrequently. We, several years later, analyzed our database and learned that in real life, 20%, 1 in every 5 patients with venous thromboembolism has at least one of the common exclusion criteria to be involved in randomized trials. Recent major bleeding, thrombocytopenia, severe renal insufficiency, pregnancy, liver insufficiency, disseminated malignancy. These patients are not uncommon, 1 in every 5 in real life. And of course they have much worse outcome during the course of anticoagulant therapy. So these patients are not infrequent, 1 in every 5, and have a much worse outcome than what we learn from randomized trials. And there is no evidence about how to manage them. Right. So my idea was from the lady with pulmonary embolism shortly after an intracerebral bleeding. My idea was that if we were able, we in the hospital, together with other colleagues, friends, experts on treating patients with VTE, if we were able to put all our consecutive patients with VTE in a unique database, maybe we will be able over time to gather information on a significant, a substantial amount of patients so as to learn a little bit more about the natural history of VTE in these heterogeneous subgroups of patients that never appear in the guidelines in the literature. And 5 years later, we learned that we published our first study on this topic, VTE after a major bleeding, and we learned that 2 weeks makes the difference. All those patients developing a VTE less than 15 days before a major bleeding have a much worse outcome, a much higher mortality rate than patients with VTE and no recent bleeding. However, for those patients with recent bleeding in the brain, gastrointestinal, or wherever, but with a difference, a time over 2 weeks between the major bleeding and the VTE event, the outcome is absolutely comparable to patients without VTE, and we can treat these patients with anticoagulants without the risk, the increased risk for bleeding.
Amazing.
that's what we learned, because at that very moment I went to the internet, I went to the guidelines, I went to look for cohorts of patients with the same clinical scenario, and we found nothing. And my question, David, for you is why there is no recommendation, no suggestion about how to treat, how to manage these patients in the guidelines?
That is a very interesting question. I had the opportunity to be a member of the panel of the ACCP guidelines that were published in 2016, and for those guidelines we released 53 recommendations on how to treat patients with venous thromboembolism. And do you know how many of these recommendations were grade 1A, the highest level of evidence?
Very few?
None. Zero. So there are so many gaps in the literature on how to treat these patients with venous thromboembolism. Only 19 of these 53 recommendations were grade 1V. So we need to have some data on how to treat not so infrequent cases in clinical practice. It is also true that we performed a practical exercise some months ago. We took our patients from our database in Ramon y Cajal Hospital, and we decided to see how many of the patients were treated according to well-defined guideline recommendations. And we were very surprised because 20% of these patients, clinicians didn't follow guideline recommendations. And for those patients in which clinicians don't follow recommendations, the risk of 30-day all-cause mortality and the risk of 30-day peer-related mortality are significantly increased. And it is interesting because you may say that this is a local experience with not a so high number of patients, but we tried to validate these results in the RIETE Registry. 34,000 patients with PE from the RIETE Registry, and we had identical results. So to make the story short, I will say that there are so many gaps in the guidelines on how to treat patients with venous thromboembolism, but for those scenarios in which we have strong evidence, please follow the evidence.
Yeah. So the conclusion is clear. For patients usually appearing in randomized trials, we must follow the recommendations of the guidelines because they assure us a better outcome for our patients. But what for patients that never appear in randomized trials? We need some complementary source of information.
This is one of the very strong part of the RIETE Registry. We can pick up some examples. For instance, every clinical practice guideline recommend the insertion of an inferior vena cava filter for patients with contraindication to anticoagulant therapy. And this is very good, but this is based on a randomized clinical trial, the PREP trial that was published in the 90s, last century, in which patients with venous thromboembolism, deep vein thrombosis, and a high risk for pulmonary embolism were randomized to filter or no filter. But every patient in this randomized clinical trial received anticoagulant therapy. And on the basis of a randomized clinical trial in which every patient received anticoagulant therapy, we provide recommendations for those patients with contraindication to anticoagulant therapy. And this is the reason why we decided to use data from the RIETE Registry to see the effectiveness and safety of inferior vena cava filter in this clinical scenario. We were able to pick patients with contraindication to anticoagulant therapy who receive an inferior vena cava filter according to the decision of the attending physician. And we matched these patients with very similar baseline characteristics but who did not receive an inferior vena cava filter. And what we learned is that 30-day peer-related mortality was significantly reduced for those patients who receive a filter as compared to those patients who did not receive a filter. We have many more different examples. You know very sure the data for those patients with acute symptomatic pulmonary embolism who present with hemodynamic instability. We have very recent data for these patients, 1,200 patients with hemodynamically unstable pulmonary embolism. And it may be seen that these numbers are not so high, but I can tell you that these are threefold higher as compared to every study on unstable patients with PE published in the literature. And we were able to see that for these patients for whom clinical practice guidelines recommend reperfusion therapies, only 20% of these patients receive reperfusion therapies in clinical practice. And 30-day outcomes were significantly worse for those patients who did not receive reperfusion therapies as compared to those patients who did receive reperfusion therapies. And we can say this only because of the data provided by the RIETE Registry.
And this is the story. RIETE started 17 years ago in March 2001 in 25 Spanish hospitals. At the very beginning there were 175 variables per patient because I was afraid, I was concerned about whether or not my colleagues will become exhausted to recruit every day or every 2 days the data from their patients and to put this information into the database for free, because you perfectly know never, no doctor, no RIETE member has received any fee for recruiting patients. We do that, and we keep doing that even 17 years later, because we believe on the project, because we realize, we learn that it helps us to better understand the natural history of the disease and to better manage our patients. We started in 25 centers in Spain. Then we tried to expand to join more colleagues, to expand the RIETE to other centers. In 2006, we translated the database into English and tried to convince more colleagues outside Spain. And nowadays, we have 245 active centers in 25 countries, in Europe, in North America, and South America, and the north of Africa, in Asia too. We progressively increased the number of variables per patient, 175 at the very beginning, but since we realized that the recruitment rate didn't decrease over time, we have been incorporating newer variables, and at this very moment we have the possibility to fill over 1,000 variables per patient.
That is incredible. You did a strong work, because it is very difficult to engage. It is very difficult to engage so many clinicians, so many sites. I have a methodological question, and I think it is important. How are we sure that we are enrolling consecutive patients in the RIETE Registry?
Thank you for the question. I said that no doctor has received any fee for recruiting patients, but we have some sponsorship. We have a sponsorship from SANOFI in Spain and from Bayer outside Spain to cover the expenses for the statistical analysis, the informatics, the server, and the quality control. There are several tools for making sure that there are no contradictions when filling the data into the electronic database. But we also have a team of CROs that periodically goes to the hospitals, like in the randomized trials, to check the files and to make sure that the information in the files in the hospital agrees with the information in the database, and to make sure also that patients have been consecutively recruited to avoid bias.
That's very interesting. I think that the RIETE Registry had different strengths. Number one, to provide recommendations for those patients that are excluded from randomized clinical trials. I think we agree with that. Number two, to give some advice for those subgroup of patients. I can remember a very recent study by Dr. Barrios regarding right heart thrombi in patients with acute symptomatic pulmonary embolism, providing very good information regarding that we should go for reperfusion therapies only for those high-risk patients according to risk stratification algorithms, but we can have also some information for elderly patients, for patients with renal insufficiency. Do you have any message for these patients with renal insufficiency?
Yes, of course. For renal insufficiency, you know that patients with severe renal insufficiency are forbidden to be recruited in randomized trials. There are pregnant women and so on. And if you remember what the guidelines said, not the last version of the ACCP guidelines, but earlier editions of the guidelines, based on the opinion of experts and based on the different pharmacokinetics of unfractionated heparin and low molecular weight heparin, the past guidelines suggested the benefit to treat patients with VTE, patients with severe renal insufficiency with unfractionated heparin over low molecular weight heparin. Right. But we published a study based on the data on RIETE in the American Journal of Medicine 3-4 years ago, where we compared, applying a propensity score matching analysis, the outcome during the first 15 days of therapy in VTE patients receiving initial therapy with unfractionated heparin versus similar patients but treated with a low molecular weight heparin. And in contrast to what the experts suggested, patients receiving low molecular weight heparin had the same rate of major bleeding, the same rate of minimum fatal bleeding, but half the rate of all-cause mortality and a significant decrease in the rate of fatal PD. So there are reasons to recommend the use of low molecular weight heparin for this particular subgroup of patients. And I always used to mention the example of our colleagues, the oncologists. Yeah. For the treatment of cancer, 25, 30 years ago, all patients with lung cancer receive according to the degree, to the presence of metastasis or not, but all of them, or most of them, received the same therapeutic approach as did patients with colorectal, with breast cancer, prostate cancer. But during these 25, 30 years, they have been progressively learning to tailor the anti-cancer therapy according to a number of variables, DNA, macroparticles, receptors, right. Other clinical characteristics, and they learn and they taught us the advantages of tailoring therapy according to the characteristics of every patient. 30 or 25 years later, we keep treating our patients with cancer. And VTE, the same we did 25 Absolutely. Years ago. I'm firmly convinced that we will be able in the future to understand and to discover what subgroups of patients would benefit from treatment with low molecular weight heparin, which ones with vitamin K, with a direct oral anticoagulant. There are no reasons to suspect that all VTE patients should receive the same therapy. Sure. But I have a question for you, David. You really believe that this impressive amount of information we are gathering in RIETE really help us to treat our patients better?
I think so. I think so. And these are data from the RIETE Registry published in JACC 2016. And what you can see here is that those patients that were diagnosed with pulmonary embolism in 2013 and were treated had better survivals, 30-day all-cause mortality and 30-day peer-related mortality, as compared to those patients that were diagnosed with pulmonary embolism and treated accordingly in 2001. Of course, that this study, these trends, were subjected to bias, to some kind of bias, but we performed so many different sub-analyses. We differentiated between those patients that were diagnosed with VQ scan as compared to those patients who were diagnosed with CT scan, results were identical. We tried to assess the baseline characteristics of those patients with PE in 2001 as compared to those patients diagnosed with PE in 2013. The results were very similar. They were not more severe in 2001 as compared to 2013. So I think that we have a very good feeling suggesting that all these things that we have learned from those patients enrolled in the RIETE registry had a significant impact in the survival of our patients with acute symptomatic pulmonary embolism and with venous thromboembolism.
And if I'm not wrong, even more, you had the opportunity to validate these findings, not in another cohort of PE patients, but in the cohort of patients with DVT also in RIETE.
That is right.
And what did you find?
Exactly the same. No matter if the patient enrolled RIETE with venous thromboembolism, deep vein thrombosis, or with pulmonary embolism, the results were identical. So this lady who was the spark of this very amazing project, the RIETE registry, how did you treat her?
At that moment, I treat her with a vena cava filter and prophylactic doses of low molecular weight heparin. It happened to learn 15, 17 years later that this seems a good approach.
Very good, very good. So now we have some time to take your questions and your comments. Thank you very much, Manuel.
You're welcome. Thanks to you. There are questions from the audience? Do you have data in RIETE about the treatment of obese patients? We do have. We published a couple of studies on this topic. First one, we compared the outcome during the first 15 days of therapy in patients. We classified patients according to body weight in 4 subgroups, and we demonstrated an inverse correlation between body weight and survival. So the obese survived more than the thin. Then we replied with a similar design the study, but classifying patients not according to body weight, but according to body mass index with similar results. And we have nowadays a very expert team in the United States that is actively studying on this topic. Should patients, the very obese, receive a tapered dose of low molecular weight heparin or whatever? Or we are currently working on this topic. And
in my opinion, the bottom line is that RIETE is very good as hypothesis generating.
Absolutely.
And at the very beginning, I think that I can remember that we were thinking that obese patients will do worse as compared to normal weight patients. But what we found in the RIETE registry is that underweight patients are the ones that do worse.
Exactly.
That's very important.
Exactly. There is another question. What about postoperative prophylaxis? Is there good evidence, and can we use the registry in some way for this? No, unfortunately not. To have some conclusions about the use of thromboprophylaxis, we will need 2 populations, patients receiving or not receiving prophylaxis, but patients developing VTE and patients not developing VTE after surgery or after immobility. Or other, unfortunately, in RIETE, we only gather information on patients that did develop VTE, so we cannot compare patients with versus without VTE.
However, correct me if I am wrong, but we have some idea regarding the time course of post-operative venous thromboembolism, and these are important results.
Yes.
Can you comment on that?
On this particular topic, on post-operative VTE, we have a couple of studies in the literature, and we demonstrated that the time course first, shortly after surgery, first the most likely VTE presentation is pulmonary embolism, while the patient is still in hospital, the first 2 weeks, but then DVT becomes more and more common than pulmonary embolism, and some relationship between the dose and the duration of prophylaxis too.
Yeah, right. Absolutely.
Use tenecteplase recommended. This is a question for you, David.
I think this is a question dealing with reperfusion therapies in patients with acute symptomatic pulmonary embolism. And I think that RIETE is less useful for this subgroup of patients because we have good randomized clinical trials demonstrated that although tenecteplase is effective for our patients with intermediate high-risk pulmonary embolism, the other side of the coin, safety is not so good. And this is the reason why clinical practice guidelines do not recommend reperfusion therapies, I mean thrombolytic therapy, for those patients who are hemodynamically stable, though they have myocardial injury and right ventricular dysfunction.
There is another question. It says, does the registry include treatment of superficial thrombophlebitis? Yes, at the very beginning we only accepted patients with pulmonary embolism or deep vein thrombosis in the lower or in the upper extremities. But over time, since we realized that the recruitment rate kept rising, we have been incorporating other kind of patients. Superficial vein thrombosis, one of them, retinal vein thrombosis, splenic abdominal vein thrombosis too, and we, at this very moment, concerning superficial vein thrombosis, at this very moment there are around 1,000 patients with superficial vein thrombosis. Then this is another question, what guidelines do we recommend? This is a question for you, David.
Well, in my opinion, I would recommend the ACCP guidelines for managing this kind of patients. There is a very good update in these guidelines, so I would recommend those guidelines. They were published in CHEST 2016. Yeah. We have a more subgroup of patients as compared to the old days. For example, incidental PE. I think it is important that at the very beginning you only accepted those patients with symptomatic VTE, but now RIETE is accepting patients with asymptomatic VTE, and I think there are good data published recently.
I didn't mention, but yes, we also are incorporating patients with incidentally found pulmonary embolism. There is an interesting question. Do you have any clues on how to treat VTE in different types of cancer? We published our experience in the American Journal of Medicine early this year. We compared the outcome in 4 subgroups of patients with VTE and cancer. Around 1,000 patients with breast cancer and VTE, 800 patients with prostatic cancer and VTE, 1,200 patients with colorectal cancer and VTE, and 1,200 patients with lung cancer. And we learned a very interesting finding. In patients with breast cancer and in patients with colorectal cancer, the rate of VTE recurrence, symptomatic VTE recurrences during therapy, and the rate of major bleeding events during therapy was very similar. The amount was different comparing breast versus colorectal, but the two extremes were very well balanced in the two subgroups. On the contrary, in patients with prostatic cancer and VTE during therapy, the same therapy applied to colorectal and to breast, the rate of major bleeding was 2-fold higher than the rate of VTE recurrences, mostly genitourinary, but major bleeding events. And on the other side, patients with lung cancer and VTE had, during therapy, a 3-fold higher rate of VTE recurrences, most of them as a recurrent PE, than major bleeding. So there are reasons to suggest that not all cancer patients with VTE should receive the same therapy.
Interesting. I think it is important to mention that RIETE is also an incredible source of prognostic models. We have prognostic models for short-term prognosis in acute PE. The simplified PESI was validated in the RIETE Registry. We have prognostic models for cancer patients with pulmonary embolism. We had prognostic models very recent published by Luis Jara Palomares for occult cancer in patients with previous venous thromboembolism. So I think it is important. Of course, do we have recent data with DOACs in clinical practice from the RIETE Registry?
Yeah, we have already published a couple of studies. First one reporting that in real life, 1 in every 4 patients with VTE receiving DOACs are treated with different doses of the recommended in the guidelines, different doses of different regimens. And for these patients, the majority of them received lower than recommended doses. There is no benefit at all. The rate of measured bleeding in patients receiving lower than recommended doses was similar to those receiving the recommended doses, but the rate of VTE recurrences was much higher, 10 times higher. This is the first study. The second study was we published concerned patients that are excluded to be recruited in randomized trials. Some of these patients in real life have been prescribed with DOACs, and we compare the rate of VTE recurrences and the rate of measured bleeding in these subgroups of patients with exclusion criteria and the DOACs as in patients participating in randomized trials work much better.
Interesting. So I think it is time to wrap up. Thanks to you. Thanks for building this incredible project. I think we should also thank to every RIETE investigators. You are doing a great effort, and thank you all.
And thanks, David.